Welcome to this episode of Season 6 of The Common Bridge, where policy and current events are discussed in a fiercely nonpartisan manner. The host, Richard Helppie, is a philanthropist, entrepreneur, and political analyst who has reached over 5 million listeners, viewers, and readers around the world. With our surging growth in audience and subscriptions, The Common Bridge continues to expand its reach. The show is available on the Substack website and the Substack app. Simply search for The Common Bridge. You can also find us on YouTube and wherever you get your podcasts. The Common Bridge draws guests and audiences from around the political spectrum, and we invite you to become a free or paid subscriber on your favorite medium.
Back to business as usual, and the health system's getting back on their feet. We're still
trying to recapture that lost volume, which generates the margin, so that whether you're a profit or nonprofit.
To be fair, there was a lot of deferred care during the COVID that people couldn't come in for their screenings and their treatments, and that there was a bit of a backlog. And on the vaccines, we did have Dr. Jim Baker on 5 times. Renowned physician, immunologist, and ran the vaccine program at Merck, and also was in the United States Army, where they were, literally weaponizing viruses. So, very germane. For you Navy men, I didn't know if I should bring up the fact that he was in the Army, but it was just too good of a connect like that. So, anything else under COVID, Matt or Dave? Anything that we did well, or
Rich, you just said the operative word: business as usual. So when I talk to house staff and other groups and healthcare providers, and they ask me about an old guy like me who remembers when rock candy was just a nickel, the changes that have evolved. This is a little bit too trite, but it's not untrue. One of the greater changes in the way healthcare has evolved, as Barry and Dave have said, is that doctors used to hire business experts to run their offices. And now business experts hire doctors to work in theirs. And that has, in some ways, created a better footing for supply and demand and cost plus inventory. But it's also put a complete business spin on the way we do it. I took a year for a master's. The Navy sent me to the Eisenhower School of Leadership, where I graduated with a master's in the elements of national power. And that includes our GDP, our agriculture, our military-industrial complex, our production of software and technology. It does not include healthcare. The healthcare is not looked at as an element of national power. And we found that out the hard way during COVID, when it knocked us completely off our blocks. And we have no surge capacity in this country because we practice on tried and true business practices, which is just-in-time inventory control to minimize capital that's tied up for no good use. So, and Barry and Dave have both opined that what are we doing to prevent the next one that may be around the corner or 20 years from now? And so I think the challenge is that we have to recognize that we cannot use totally pristine business practices in healthcare, and we have to have surpluses. We have to have surge. The military is often chided for, big hospitals that are underutilized. Well, yes, until time of war, until time of pandemics. When I was running hospitals in the military and there was a huge influenza outbreak, an unusual one, but one that was creating tremendous morbidity and mortality, civilian hospitals in our areas would call us up and ask if they could use some of our extra ventilators. And so that kind of surge capacity, I think, is pivotal to making healthcare an element of national power. So, and then vaccines, right? And then the other trouble, and this is just a passion point of mine, and then I'll stop. One of the reasons I think physicians become so disenchanted and so disenfranchised is they almost feel they have an adversarial position now with a lot of the population, a lot of their patients, in the sense that over the last 80 years, vaccines have literally saved and stemmed morbidity and mortality for millions and millions of people. And yet today, some physicians feel if they get up and get on a podium and talk about the goodness of vaccines, somebody will look at them and say, well, of course you say that because you're a doctor. And they go, well, yeah, I say that because I'm a doctor and I want to tell you what I think is good practice for you to protect yourself against. And they feel that instead of being a beacon of somebody who's respected, they feel they're part of the deep state that's being criticized for a political point of view. And that is a burden that is almost too much to bear for some providers. And so they tend to shy away from the person-to-person specialties and dealing with patients. And they run for the more remote specialties, which are very valuable and contribute, but the radiology and the pathology and the dermatology, and the ophthalmology, and those are wonderful practices, and we need them. But we're having people vote with their feet now to get away from the more contentious person-to-person, bedside confrontational things. So I think all this needs to be addressed by the medical associations as well as by policymakers, but by providers themselves, by physicians themselves. And
I'd like to add to that if I could, because it's an issue that I'm deeply concerned about. What we obviously lost a lot of cohesion with the pandemic, and we met patients in the hospital who were blue from lack of oxygen, who didn't believe in COVID and didn't want to hear that that's what they were suffering from. Or maybe they start to blame themselves for not getting a vaccine once it had been offered. And what you began to see was policy people and editorialists write in medical journals and in Washington Post, for example, that the unvaccinated should be prioritized for hospital care because they were responsible for their own illness. And some physicians who were aggressively in the middle of sort of aggressive family reaction began to write the same thing. You're asking me to come in and I'm working so hard and I got to wear this mask and stuff all day long and you don't take care of yourself. Now, we would never say that to a smoker who got lung cancer or to someone who drank to abuse, excess, and got liver cirrhosis. We don't allow ourselves to talk about that. But we did
also
during COVID.
The difference is, though, too, Barry, if I'm going to jump in, interject.
Yep.
The way that the mRNA vaccines were rolled out were a tragedy of government and reporting. So I point out one thing. The NIH is not doing a victory lap right now about, look, we conquered COVID. All right. They're not saying, look, the lockdowns worked. They're not saying the vaccines did this. And yet at the beginning, they said, oh, we found this safe and effective vaccine. And I'm thinking to myself, there hasn't been time to test it. We don't know. The right message should have been, we think this is our best chance. And let's explain to people the difference between this mRNA injection and the normal way that a vaccine is produced with the live virus being killed. And I think that deception and that absolutism versus, hey, this is the best option we have today, we think, because as it started to fail, we started inventing new words, okay? Breakthrough infection. No, it's not a breakthrough infection. The vaccine didn't work. And we started developing a nomenclature kind of around policy versus going back to the fact that medicine is an art and it's a science, and we've got to give ourselves time to make discoveries. And so that when I look at it, and you talked about vents, and remember there weren't enough ventilators. And then what did we find out during COVID? 4 out of 5 people that got on vents died. And their blood gases said they should be on a vent, but they were sitting up and talking. No, we got the term happy hypoxics. So this is where I think that we need to communicate better, is that we only know what we know, and that we can't represent that we've got a safe, proven medication or prevention when we haven't had time to really test it. And I said on my show, we're all in the petri dish.
Yeah. My concern, though, is about the lack of societal cohesion around this issue and about the lockdown.
I'm making the same point. The lack of social cohesion because of the absolutism of the absolutism of the position versus we have vulnerable populations like all of us because of our age, and that we maybe needed to be vaccinated and to limit our exposure. And yet, there was never a case to vaccinate a child ever, period. Still doesn't exist. There was never a case to close schools. And it's been proven around the world in Sweden, Florida, Great Barrington Declaration. But the bigger picture that I wanted to kind of delve into was the COVID as it pertained to, we had all of a sudden people couldn't go to the hospital, and we were asked to treat a cohort of patients with a pandemic that we didn't really understand. And at the time we needed the health system the most, the financing system would have bankrupted everybody.
So I have 3 comments. I want to reflect on a couple things said. One,
Please.
Rich, I would challenge you a bit to say that it was a vaccine failure as opposed to, I agree that maybe there's no case for vaccinating the very young, and I agree with that. I also agree with absolutism is always dangerous. I think persuasion is always better, and exposing the data, including the knowns and unknowns, is always the safer strategy, and we didn't do that. The other point I'd like to make is you ask about what COVID did and we did right. For those of us in the chronic disease field who are required, in order for patients to get the medicines that they need, we are required to see them with a certain periodicity. Even if they don't need it, they can't get their medicines unless they see us. And so for that period, we were allowed to see people virtually. And now that COVID's behind us, no, you got to bring them in again. And so it's creating unnecessary workflow problems that we know can be managed in other ways, but the system won't let us do it.
Yeah, no, these are great points, and there's so many aspects and nuances, and I will just say that based on Dr. Baker, I thought that the risk reward for me was to take the first 2 vaccines and the first booster, which I did.
Yeah,
and then as more data came out, and they couldn't figure out exactly what target they were aiming at. I thought, well, my risk reward's better just doing what I always do, build up my immune system. So anybody else, any final thoughts about COVID or vaccines at all?
Yeah, I don't want to. Just one, we all get the flu vaccine every year because the flu strain changes every year. It mutates. But then every 50 years or so, there's a major change. And I don't know if you know, Rich, but in 1918, 50 million people died of the flu that year. 50 million people. And when major changes like that come along, the immune system can't respond fast enough. So I think getting the initial COVID vaccine probably did save lots of lives. But then the subsequent ones, now that our systems have seen COVID for the most part, even if there's genetic variants, the risk has been declining because it's not an unknown virus to us anymore.
No, I understand. I mean, and I get my flu shot. I didn't for years. Then I got the flu, and it's like, oh, you know what? Rather do that.
It's a bad disease.
Shingles vaccines. If you're over 50, get the shingle vaccine. You don't want it.
Disease, yeah.
It's going to go into your eyes. You don't want to get that. It's nasty.
And Rich, I would just add that when you want to talk about COVID and how we responded to it, I always ask people which COVID, the early COVID or the COVID we're dealing with now. Because the early COVID is what created all the hell that broke loose, which was people turning on their TVs and seeing refrigerator trucks parked outside of hospitals as makeshift morgues because they couldn't keep up with the people who were dying in droves from this novel virus that nobody had any defense against. And if we had a time machine and we could have given all those people a vaccine, it would have just completely changed the game. Now, to your point, as viruses mutate and evolve, the ones that tend to evolve and continue to pass on are the ones that are less virulent and the ones that have less potential to kill. They don't want to. The ones that kill their hosts don't get propagated. The ones that make them kind of sick can get communicated. So, to your point, there's more evidence now saying, okay, do we really get bang for the buck from the vaccinations? I think it's a healthy discussion to have. Nobody should be an absolutist. No physician, no policymaker, no big pharma person should be an absolutist on this, but we should have the conversation. My previous comment was, I'm not even allowed to have the conversation with some people now because of the political discourse that exists over any position I take, whether it's for vaccines or against vaccines. I'm immediately categorized as somebody. And then if somebody says, hey, wait, he's a doctor, and half the people in the room go, well, then let's listen to him. And the other half go, the hell with him. If he's a doctor, he's already been brainwashed and is drinking the Kool-Aid. At some point, I'm just not, if I've got chest pain. Let me just tell you one quick story about human nature and statistics. I have a cardiologist during the thick of COVID for a patient who had an automatic implanted defibrillator, right? Who would go into these fatal rhythms, but their implantable defibrillator would shock them out of it. He called her up and he said, my battery's running low. And she said, well, you got to get to the hospital and we got to change your battery. He said, I'm afraid to go there because I'll catch COVID. And she said, you have a 1 out of 20 chance of dying from COVID. You probably have a 19 out of 20 chance of dying if your battery's dying this thing. They found him dead in his bed with a dead battery and his implantable defibrillator because he was terrified of going to the hospital and catching COVID. So the irrationality that existed at that time and the hyperbole that was given to everything. So we look at it with the retroscope, but it's unfair because we were in a fog of war at that time. Now let's have some healthy conversations about the good, the bad, the ugly of vaccines, which unfortunately, because of the COVID discourse, is, in my opinion, this is my opinion, we're going to see the rise again, of measles, possibly polio, maybe diphtheria, and we're going to see these things which exist endemically in other nations start to blossom again in the United States, which would be sad. So that's my comment on COVID. Which COVID do you want to talk about, early or later?
Yeah, and Rich, I just want to expand on what Matt said. I think this Common Bridge thing is such an important forum because you've created a space for people to have legitimate discussions about these things. And unfortunately,
thank you. And what the Admiral said, I think, is right on. That had he been the one delivering the updates, where it has that nuance of what we know, what we don't know, what point in time. Versus hard dictates, I think that people might have responded better. So I think healthcare is caught up in where we are as a society and as a political system and as a media system. That where is that source of truth out there?
Yeah.
And
I think public health.
Say again, Barry.
I'm sorry, I didn't mean to interrupt. Why don't you finish and then I'll add a comment.
No, I was done. Go ahead.
I think public health officials, and I've not been one, struggle with the issue of what they call blowing an uncertain trumpet. And, in communicating with the public, there's a limited amount of nuance that they can, deliver. And I think in some cases they erred in not providing more nuance. And, some of it actually, look back on, it's actually amusing now, this instruction about how many days after a case you should stay home and isolate. 14 days, 21 days, 7 days. Or you remember the instruction about not opening your mail or your packages? Let it sit out on your porch for 2 days. That might have been well intended, but in retrospect, it's amusing. But someone said that's the state we were in. You called it a fog of war. I think it was a commotion. And that's it. Never should have been said. It was nonsense on its surface. And I know people that wash their mail and stuff.
But
I know.
that this is where we need to get more clarity, and this 180 degrees from, hey, a doctor said it, well, that's a voice of authority and training, versus, well, wait a minute, you must be part of the deep state. It's just I don't have an answer for that.
Yeah.
But let's talk about some other things, and I'm going to make kind of a omnibus question here about healthcare in general, and so it's around investments and investments where we should increase or decrease. And is it medical equipment, facilities, training? And then let's try to, if we can bring in, what about the impact of information technology like electronic medical records and possibly the use of AI? And how do we train our practitioners in all this? So where should we be investing? How should we be training? What's the promise or the peril with technology? Pretty broad question, but dive in any place.
Well,
So I think you've got a bit of
I would say it's both. There's both peril and promise. It's like atomic energy, right?
Exactly.
It can cut through the nonsense. It can help with some of these corporate tasks we mentioned. It can actually make doctors more efficient, but you can't replace physician judgment or personal interaction with AI. That would be my hope, that we don't allow that to happen.
Well, but Barry, the three of us are of a generation where we grew up with, and nobody wants humanity in medicine more than I do. There's nothing I relish more than talking to my own PCP about how my life is going, how I'm doing, how much sleep I'm getting, whether I'm anxious about this or that. But studies have shown that Gen Xers and Gen Zers, they don't want that. It's a commodity. They want to get in, they want to get out. They don't really want the doctor asking them about their rose garden or what they do for a living. And so we're trying to cater to a variety of people. But to answer your question, Rich, from my perspective, and I'm very interested in the human connection in medicine, yet having graduated from Georgia Tech with a biosciences engineering major, I am very big on technology. I believe AI is going to truly be a blessing for access in routine primary care. It's going to get to the point, and people go, how can you do that? And I go, well, if it can drive a car through a busy city without a driver, it can figure out how to do enough transducer-based diagnostics on people with algorithms. Already we're seeing AI make a difference in the evaluation of funny-looking moles. Right? You can be the best dermatologist in the world, but you haven't got a database of 1.2 billion moles stored in your database that you're comparing it to, whereas AI can. We're seeing it make a difference in reading X-rays and in looking at histology on path reports. We're seeing it make a difference in the poor man's AI, which is robotics, right? Which is the surgeon being able to operate on somebody who could be 50 miles away using robotic technology. So I think that's coming. That's going to help. That's going to be a force multiplier. It's scary right now, just like I wouldn't want my surgery done by AI no more than I really want to get in a car that's driven by AI right now on the freeway at 70 miles an hour. But it'll get there. So I think we're going to get there. I think it's going to make a difference. I think technology, the challenge for educators, and Dave and Barry are famous mentors, and they have a legion of residents and medical students who would quote them and look up to them as people who set the pace. We don't want to lose the ability of this generation, which tends to be very social media centric and doesn't have as much personal skills in talking to people about difficult subjects face to face. We don't want them to lose the humanity of being able to be compassionate and being able to reach out and touch somebody on the shoulder when they're about to lose it because they've just been given bad news. We don't want people being uncomfortable and running from that. We want them to be able to feel comfortable and running to that as physicians. Not everybody shares that definition of a physician, but I do. And so I'm this dichotomy of advocating big technology, more and more ones and zeros and digitalization of healthcare, but more and more money being spent on emphasis of helping our young practitioners in nursing, allied health, and physician practices to be humane and compassionate.
I'll just add very few comments. I believe in technology-enabled care. Barry is an expert in breast cancer, and certainly AI has improved the reading of mammograms immensely. But my answer to your question, Rich, is I would not want to be proscriptive about how to use AI. I would rather create an environment where 1,000 ideas can be tested in practice and let the ones that work and are effective rise to the top. I don't think we know who the winners are going to be. And it's always dangerous when we do think we know who the winners are going to be.
Indeed. And as I listen to you all talk about this, it's about leveraging the time of the physician. That, as we talked earlier, we're going to have fewer physicians and or less hours. So leveraging with nurse practitioners, for example, and leveraging with AI that maybe someone doesn't get to the physician because it's not necessary. My father, and since you're three Navy men, I'll tell you this: my father was a Navy a sailor in World War II, and the way he described healthcare, he said, well, you know, if you were sick, you saw the guy who maybe had been a shoe repairman first, and they could take care of you. He goes, then you maybe went to the next guy who was a tailor if you had to get sewed up. And if you're really sick, you finally got up to see the doctor. And he says, we should do that. And I was, like saying, okay, Dad, good point. And now we had Brian Peters on from the Michigan Health and Hospital Association saying one of the ways to deliver better care is for everybody to be able to work at the top of their license. And then I hear you all saying, we've got these allied health professionals and we can use the technology to let us be better one-on-one with the patient. And I just see that being carried through.
Yeah.
Of course, it takes an educated patient to know at what point to access the system and an intelligent system to make sure we're not missing the person with the really odd mole that needs to be treated before it's horrible.
That's the trick, is do that. So I watched your program with the president of the Michigan Health Association. I watched it with interest. And what he's describing as a virtue, access, I will tell you, is developed because of business. So it's not good business sense to have say, orthopedic surgeon spend 80% of his available clinic time seeing people who are non-operative, back pain, hip pain. So get a physician's assistant to provide good care and refer the ones who are surgical candidates for discussion about surgery. And that is maybe access creating, but also is a good business decision. And you're seeing that all over. And you can view it as a barrier, but it's also a way of adding, access and sometimes immediate access to care.
I'm very encouraged by those kinds of things, and also, where the subspecialist can look at the data and say, I don't need to see this person again, right? That I'm going to keep my time for the people that have the specific malady that I'm most focused on. Mayo Clinic, by the way, does a great job with that in that triage. And their researchers and specialists are able to see the patient cohort that they've can best benefit. This has been a great conversation. I hope, by the way, we can do this again, and maybe we'll focus it in on one or two questions. We're trying to kind of boil the ocean here a little bit. So if you were going to look at an ideal healthcare ecosystem, what would it look like, and what are the barriers to us getting to a better place today?
Who wants to go first?
Ecosystems is Dr. Nathan's expertise.
Okay, you go first, Matt. I have comments, but I'll go whenever you guys assign me.
Well,
Matt, what do you think?
You're right. It's boiling the ocean. I often say, with tongue in cheek, there's room on Mount Rushmore for one more face, and it's the person who can figure out how to create a healthcare ecosystem that gives access fairly to all and provides the right amount of care for the right amount of cost. Because we're not doing that well now. And I think one of the biggest impediments is, and as Barry said, we didn't design it to be this way, but it's evolved this way. We now have a cadre of healthcare providers who feel that they are mostly employed. If they're not employed, they're still working very hard trying to game the system the best they can to work with insurance companies and get things approved and get things authorized and provide the care that they think their patients need and manipulate the system to get it that way. The patients feel that way. And it's going to require contributing factors from everything we've talked about. Some of it's the onus of the patient. The onus of the patient to say, I can't have everything I want every time I want it at any cost, at no cost to me or at limited cost to me. The second thing is we have to get physicians and other providers who have become sort of used to or liquored up and not happy necessarily about doing it because burnout is tremendous right now, about the more you do, the more you make. And the more care you provide, the more you make. And so human nature tends to do that. We have to break that cycle. We have to get people feeling better about themselves. When I was managing physicians in the Navy sector, every once in a while, not often, I'd have to go in the lunchroom and say, all right, you guys, get out of here and get back to seeing patients. And although they had a great work ethic, that would happen occasionally. And when I was managing physicians in the private sector, I'd say, hey, you guys, stop and take a break, eat some lunch. You're going to work yourself to death because of the difference in reward systems. In the federal sector, the reward is time. Whatever time you can get because you're paid the same. In the private sector, the reward is often income. And so people tend to equate that. So we have to create a sea change in the expectations of providers, make them feel part of the community again, make them feel that they are held in high esteem, not absolutists and not on pedestals, but held in high esteem, and that we're going to have a payment system that rewards extra years of training and extra effort and sophisticated care, such as Barry managing cancer or a surgeon doing a heart valve, but nonetheless create the real starting event, which is preventative care, primary care, getting that child, that adolescent, that young adult on a healthy pathway to a healthy lifestyle so that they can live until they're 80 and succumb to Barry, who's trying to manage their cancer, as opposed to their 60s dealing with heart disease. So it's going to require a sea change in our physician cadre, and physicians are the ones who are going to have to lead that charge. You're not going to be able to do it by passing a law.
I really like that you've talked about the caregiver and the patient, which is kind of full circle. Dave, what have you got to chip in here?
Barry, do you want to say anything? I have ideas, but I know, Barry, you have ideas.
I'll follow you.
Okay.
So go ahead.
Well, I think, Rich, what we have to do is right now, let's take, for example, this Luigi Mangione guy, who's our modern era John Brown, who, John Brown murdered people in Kansas over slavery. Terrible thing. But he because he felt so passionate about slavery, and Luigi Mangione, that whole episode, there are people, and you've heard them, even politicians, who say it's the health insurance industry, and then the health insurance industry says, "Oh no, we prevent unnecessary care and unnecessary costs. What our current system has created is an adversarial system. The doctors and the patients fighting against the patients, and that shouldn't be. So the one thing I'd like to figure out is appropriately aligning incentives. And what you said earlier, Rich, I think is a very good place to start. Get rid of the tax benefit of these hidden healthcare costs so that people see them. They need to see that this stuff isn't free and that they have a role in it. So that would be my one thing, figuring out how to align incentives toward the common goal of improved health.
Barry, anything on this one?
Yeah, I think perhaps the most important thing we've said, that at least I spend my time really concerned about, is the way the system has demoralized the physician. And it may not be visible to you if you're a consumer of healthcare, but most people go to medical school for the right reason, because they want to be in a helping profession. Although there are studies that show empathy loss occurs during medical school, they still come out into the workplace with the desire to be a force for good. And then they get caught up in this system and they're told they got to see more patients faster. You learn to ask for one problem at a time so you can see a patient every 15 minutes. Or if you work in a hospital, there's corporate pressure to move the patient through the system faster and faster. And we've lost track of our ability to connect. In fact, Matt and Dave will know well, famous quote by one of the exemplars of our field, William Osler, who said famously, "A good physician treats the disease. A great physician treats the person with a disease." And I think he actually might have got that from Maimonides, who in fact might have got it from Hippocrates. So it's been a truism for almost 3,000 years, and the system doesn't allow us to do that. And so we end up with disappointed, morally injured physicians, and I think care suffers when there's no time to get to know the person. So by fixing this business-driven medical decision-making, we can restore the joy of medicine to our cadre of physicians who are going to have to lead this improvement in care. And all these things will contribute to that improvement.
Yeah, and let's get it back to that patient-physician partnership where patients, take care of your health.
Yes.
And communicate and let the physician do their practice without unnecessary burdens. But also, we have a societal expectation that somehow people can choose anything they want without regard to cost or effectiveness. And what I've said before, that there is no benevolent bureaucracy any place in the world eager to pay for healthcare, public or private, period. And there are many people, like all three of you, who are passionately wanting to deliver a healthy person, whether that's the relief from an awful disease like cancer, or resolution of your chronic illness like diabetes, or if it's just, can you be healthier so that you can be a better sailor for our naval? It's all the same thing, and we've got some structural issues. Gentlemen, we've got time for a quick lightning round here, and I'm going to give you all 40 seconds or so. Just what did we not talk about today that we should have covered, or perhaps any closing thoughts?
I'll close with something that's gotten me in trouble, Rich, and I've quoted history lots, and I love the preamble to our Constitution that says, life, liberty, and the pursuit of happiness. And it didn't say life, liberty, and happiness, because no one can guarantee your happiness. They can give you an opportunity to pursue happiness. And what I said in front of the medical school class is, if I could amend it today, I would say life, liberty, and the pursuit of happiness and health, but you have to pursue it. And the medical students were offended by that. What do you mean patients have to pursue it? You have, but I think we need to get back to that. There has to be a buy-in from all of us to promote the national health.
Barry or Matt?
I would say that we had a pretty thorough hearing on all the issues, big and small, to worry about. I would close by saying that people should have confidence in healthcare delivery because it can accomplish some pretty amazing things, even if it's not evenly distributed. And our goal is to keep what's great, fix what's poor. And it does. It's going to rely on a multifocal group of initiatives, and I think the public's got to be part of it, and their unhappiness is going to drive it.
Terrific.
And I agree. I mean, it's healthcare challenges are like the weather. Everybody's talking about them. Unfortunately, some people are taking it into their own hands and creating homicide as a result of it. But nobody's doing anything about it. And I'm encouraged by the young people going into the healthcare practices today. I'm encouraged by the nursing students and the young students doing it. They seem to be altruistic. The challenge is that, and we didn't really talk about this, the challenge is that the priority today, and it's not necessarily a bad one, is time. My time is my time. And so we're having trouble recruiting providers to go into the practices that do get up in the middle of the night and go to the hospital or do have to work every other weekend. It's just a social mores, and the older physicians may criticize that and say these whippersnappers don't understand what it means to be dedicated to your patients. And younger people may say you don't understand what it means to have a quality lifestyle where I have less domestic upheavalment and I enjoy my children more. So we have to leverage all these things that we've talked about in order to create a better balance of health for the caregiver, care for the caregiver, as well as for our patients. And I stand on what I said, which I believe it's a national disgrace if you have two zip codes because one community is an affluent community and has insurance and third-party payers and access to primary care, and the zip code over is in the underserved, rundown population. And studies have clearly shown that there's a lifespan difference of at least as much as 10 years on average in those populations. That shouldn't be happening in this country. It just shouldn't. We have the wherewithal to fix that. And I believe a lot of young people going into the practice want to do that. And to Barry's and Dave's comments, they then get consumed by the way they have to practice and game the system to see the patients they want to see. And they eventually say, I can't beat them, so I'll join them. We have to have a collective philosophy among the caregivers in this country to say, I'm tired of joining them. I want to beat them, and I want to get back to a system where all people have a good shot at health care. There's always going to be the haves that have a little better, but the haves shouldn't have 10 years more lifestyle of life than somebody else. So thank you for the opportunity to talk about this. I appreciate it. And it's always a honor to be included on the same dais as Dave and Barry.
Well, gentlemen, thank you all for being on the Common Bridge. We've been talking with doctors and Admiral Matt Nathan, Dr. David Harlan, and Dr. Barry Meisenberg. Even though this is probably going to be 2 episodes, we've only begun to cover the waterfront in healthcare. But healthcare is very important because ultimately we're all patients at some point. And of course, we're always going to be caregivers to those that we love. And with our guest today, this is your host, Rich Helppie, signing off on the Common Bridge.
Thanks for joining us on the Common Bridge. Subscribe to the Common Bridge on Substack.com or use their Substack app, where you can find more interviews, columns, videos, and nonpartisan discussions of the day. Just search for the Common Bridge. You can also find the Common Bridge on Mission Control Radio on your Radio Garden app.